Good morning. Welcome to the ADOPT Toolkit webinar. Our toolkit is focusing on planning and building best-in-class mobile health programs for chronic disease management. My name is David Lindeman, Director of the Center for Technology and Aging, and I'll be serving as the moderator today for our program. As this audience knows quite well, chronic disease is the greatest driver of healthcare and healthcare costs in the U.S. As we're continuing to implement system transformation, technology is going to be particularly helpful in this area, especially that around mobile health and wireless technologies. They're going to play an important role in how healthcare is delivered, how patients with chronic disease can receive better care and have better outcomes, and ultimately how we can reduce costs to the healthcare system. Today we're going to be talking about the ADOPT Toolkit, which adds new mechanisms and techniques for folks in the provider community in terms of addressing the ongoing issues around chronic disease management. Two housekeeping rules before we start. First, just like to mention if there are any WebEx problems, please call the 866 number on your screen. And if there are any audio difficulties, as you are participating in the program, feel free to email Val Steinmetz at techandaging.org. As we go through the program, we're going to hold questions and answers till the end. Please send those questions to using your chat feature on the WebEx and send it to all panelists, please. I'm joined today by three outstanding individuals in the field of healthcare and specialists in mobile technology. Alex Baker is joining us from ONC, the Office of National Coordinator for Health Information Technology. Korey Capozza is joining us from HealthInsight in Utah. And Jason Broad will be joining us from Sharp Healthcare in Southern California. Today's agenda is going to cover a number of points. We'd like to make sure that you have a context and background as to how the toolkit has been developed and some of the organizations that have contributed to it. We're going to follow that with some very brief examples of how to use the toolkit. And then we're going to turn the program over to our two colleagues who have actually been implementing programs, mHealth programs, using these tools and have helped develop them so that you'll hear more about the HealthInsight and Sharp Healthcare programs. And finally, we're going to take time to give you very concrete examples showing you different tools in different capacities and how they can be used in your own organization and give you a sense just what the toolkit consists of. So without further ado, turning to some background, the Center for Technology and Aging is focused on the idea that we can accelerate diffusion of proven technologies to improve chronic care disease. We're clearly focused on how to achieve the triple aims in terms of promoting better care, better outcomes, and achieving lower costs. And ultimately, because we are focused on gerontological population, we're looking at how we can improve the independence of older adults wherever they are residing. We've conducted technology demonstration projects now with different organizations ranging from home care agencies to hospitals and health systems around the country. And our results have now been put together both in terms of professional presentations, research reports, and being implemented in terms of public policy. The specific types of material that you're seeing today have been a result of our primary demonstration grant program that has gone on for the last 3 years, where we have focused on 4 different technology issues, different types of care delivery mechanisms, as well as different platforms for using technology to improve chronic care. And today's material has been developed not only from the program with mobile health solutions from our grantees that have been involved in that, but also from several other grantees and specialists in other areas. Before going on with Center for Technology and Aging, I'd now like to introduce Alex Baker, who is Program Officer for the Beacon Community Program at the Office of the National Coordinator, who will speak to our collaborative work and how we have worked to put together this toolkit in conjunction with members of the Beacon community. So I will turn the speaker over to Alex, who will take us through some of the background on the Beacon Community Program.
Thanks, David. Can you all hear me?
Yeah, very clear.
Great. So I just wanted to give a little bit of background on the Beacon Community Program if folks aren't familiar with it. The Beacon Community Program was included as part of the HITECH Act in the Recovery Act in 2009 and provided $12 to $16 million over 3 years to 17 communities to really focus on what we call the 3 pillars of the program. So the first, as you can see here, is building and strengthening health IT infrastructure. So really looking at the community context and trying to enhance the IT infrastructure, both in terms of EHR adoption, in terms of other ways to do IT-enabled practice optimization, but also with a big focus on health information exchange, both for point-to-point communication as well as being able to aggregate clinical and claims data across the community to really look at population health. The second pillar that the Beacons focused on was improving cost, quality, and population health. So this is a set of activities that really tries to, in a relatively short period of time, demonstrate how strategies can, clinical interventions and the like, can improve outcome measures for patients and really change the way the care is delivered. And then the final pillar that was part of the program was testing innovative approaches. So this was really a mandate to Beacons to look out at the world of technology-enabled care delivery and test some of these new approaches, test some of these new tools, and so that at the end of the program we could say that this investment had really contributed something to the evidence base for these emerging tools. So next slide. So here are the 17 Beacon communities. As you can see, really a wide range of geography and demographics across the country that are represented by these 17 grants, both in terms of those elements, but also something that's been particularly interesting to see during the program has been how different communities have tackled very different market environments. So clearly we have communities that are dominated by very competitive, sophisticated delivery systems, all the way to communities that are primarily contending with the problems of underserved rural settings. And so within all of these diverse settings, each Beacon really was given freedom to choose their own target populations, the chronic conditions that they would focus on, and the quality measures that they would use to track their progress. So we have a number of Beacons that have focused on populations with diabetes exclusively, others that have focused on patients with congestive heart failure and COPD, other communities that have focused on pediatric asthma, and the measures that they're collecting reflect those different populations of focus, both in terms of indicators of control for those conditions, as well as a number of communities that are focused on measures tracking inappropriate use of acute care, so readmissions and ED visits and the like. What have Beacons been doing for the past 3 years? This is just, this slide is just a little bit of a flavor of the different projects that communities have carried out. So as I mentioned, a lot of focus on strengthening community-level exchange capabilities. There were a number of communities that did not have a really robust community-wide exchange solution at the beginning of the program, and those communities have worked to invest in that capability. But we've also had a number of communities that did have existing exchanges and used the funding to add additional data sources, add additional functionality, and really think about how to use Exchange to look to the future and look to the next wave of care delivery reforms. A lot of, so for instance, one of those pieces that a lot of communities was focused on was using Exchange to deliver alerts from hospitals to primary care practices. Also have a lot of communities that are very much focused on delivering changes in the practice setting. So being able to deliver data directly to providers that they can use to deliver better care and manage patient populations. And then finally, here as we're getting towards the end of the program, I think important theme we've seen is that many of the communities where there were beacon investments are now using that infrastructure and capabilities developed under the program to support a lot of the new innovation models that are coming out from CMS as part of the Affordable Care Act. So we have 3 of the 7 comprehensive primary care initiative markets that overlap with beacon markets and are using some of the infrastructure developed there. Have a number of different communities where infrastructure developed under Beacon is now serving pioneer ACOs and other MSSP participants in those markets, and then an even further set that are serving different additional public initiatives as well as emerging private ACOs. So next slide. And so here is just a look at a lot of the communities that really have served as the locus of our collaboration with CTA over the past several years, which has been just a hugely rewarding opportunity to collaborate, particularly around beacons that are testing, really working on that 3rd pillar that I mentioned previously around testing innovative approaches. So we have a number of beacons that are working on mobile approaches, a number of beacons that are working on remote patient monitoring, and as well as patient portals and additional tools. And today you will hear from 2 of those grantees that both we and CTA have worked with from Utah and San Diego. So next slide. So just in closing, I wanted to mention a project that we are now working on because I think it's really of a kindred spirit with what CTA has done with their toolkits and what they'll be talking about today. And that is what we're calling the Beacon Nation Project, which is really an attempt to synthesize the lessons that beacons have learned over the past several years. Not on everything, although there's certainly a lot of research that the communities are producing, but to ask if we could really focus on some of the quote-unquote best bets that have emerged from the communities, create some user-friendly materials, and work with other beacon-like communities around the country to try to spread those innovations. And so in doing that, you know, we have looked at what CTA has done and are definitely working to collaborate around some of the common themes. And I think, you know, from our perspective, the work with the toolkits has been such a fantastic model in how to really think about investments that have been made in grantee work and how those can be spread to across the nation and really get the best benefit possible out of them. So with that, I will turn it back to David.
Thank you, Alex. And again, we've appreciated and certainly benefited from this collaboration over the last several years. What I'd like to mention also are the impact and some of the results from the Center for Technology and Aging grant program, in that we did have 22 grantees working in a similar vein as the Beacon communities, and now reporting out their results. And particularly in regard to the emphasis that we now have on the triple aims, and as we work towards implementing the Affordable Care Act, we've found some very exciting findings across our different programs in addressing some of those issues, particularly just in the readmissions issue, where we had 12 programs who were focused on this, and 10 not only succeeded, but 5 actually had very significant reductions in readmissions. The examples of these programs are on our website, and the types of interventions they used, and again, how they implemented their programs can be found on the Tech and Aging, www.techandaging.org website. We also saw significant improvements in satisfaction engagement using technology-enhanced programs from most of the programs, and very excitingly, as we've now introduced a new return on investment model, those programs that were actually measuring how their technology-enabled intervention was leading towards, or if it could lead to cost savings, we did find significant benefits and actual differences in their ROIs, and we will be speaking to that as the session goes on this morning. In terms of the other aspect of the program, a key issue for the Center for Technology and Aging and for all folks who are looking at implementing technology-enabled programs is, are they sustainable? Can they be taken to scale? And we're very pleased to report that out of the 22 programs, 10 of ours did take their programs to scale, and several of them not only expanded beyond or within their own healthcare system, but 4 actually took their programs national. Again, information on those is available on our website. But there was a key takeaway that we had from these programs, because what we've come to realize as we've looked at this process is that the adoption of technology and full deployment is very minimally involved around the technology itself. And those who have followed our work again and again realize that we keep coming back to key issues within an organization, and that is everything from having a champion to lead technology-enabled programs implementation, to organizations who are most successful having a very good handle on change management, how to address workflow processes, and work very closely with patients and providers. For those to be successful, there is so much more that needs to be done, and that led to the generation of the ADOPT Toolkit. So with that, we'd like to start taking you through the examples of the ADOPT Toolkit. First, just a little background on where it came from, and as we've talked about, its basic goal is to help all organizations who are addressing not only chronic disease management issues, but very specific challenges in healthcare using different types of telehealth and mobile health technologies to improve care outcomes. We've been fortunate to have not only our colleagues at ONC, but a number of grantees, both within both organizations, but a lot of additional experts contribute to this toolkit. It's a web-based program which is set up with both guides, practical examples, models, and templates for organizations to use. And I'd be remiss if I didn't thank the many organizations that have helped contribute to the development of the toolkit, the SCAN Foundation, McKesson Foundation, Gordon and Betty Moore Foundation, California Healthcare Foundation, and the Commonwealth Fund, and of course, the ONC. In terms of the toolkit, we've had a number of the material you're going to see today, and as you get onto the toolkit, you'll see that it has been drawn from a range of different types of healthcare providers. Wanted to make sure that people realize that these are not the tools that are not just accessible or useful for programs in hospitals or home health agency, but across the spectrum. As you can see from this list, it consists of not only hospitals and health systems, but county organized health systems, home care agency, community-based organizations, community clinics, and physician groups, all of whom contributed to this. So when you're starting on this and how one looks at the ADOPT Toolkit, it's not just looking at planning and designing and implementing a program that's technology-enabled, but it requires looking at all the other issues that we started talking about, looking at the operational workflow components of an intervention, using data to help make better decisions, being able to engage both patient and providers. And from the outset, one has to consider evaluating the impact of the program, how it will be sustainable and scalable. And again, that is the fundamental goal of the ADOPT Toolkit, to help organizations do that from the beginning. So you can find the ADOPT Toolkit first on our CTA webpage. It has its own homepage that you can go to immediately. And within this, we do have a login process simply to help track individuals who are using the toolkit. And you can very easily, once you register, move into all aspects of the toolkit. We have it divided into 4 fundamental areas based on the types of tools that were submitted from the participating organizations. They're not mutually exclusive. There are many that are basically used in different capacities, different types of care processes, or using different technology platforms. So we've included a mechanism to provide access to a broad number of the tools in each of the 4 areas, but it allows you to focus on a key area that you are most interested in. The toolkits themselves are divided into 8 work streams. We identified the key programmatic areas that our grantees and experts identified as necessary to work in this space, and have divided the tools accordingly. But it's important to realize that these work streams are not sequential in order. They basically allow you to go to any area at any time, and you can self-select what you would like to use, or the key elements that you need to look at in terms of the needs of your own organization. In terms of the actual, what one would find within each work stream, using the example of program planning, we have specific information not only about the broader area, but sub-areas. We have different tasks that go into each area and have divided the tools accordingly. We'd like to encourage people to look at the guides, the program guides that have been prepared for each area, because they give background and examples overall, particularly those organizations that are just looking at technology-enabled programs for the first time. The mechanism for using the toolkit then is very straightforward. You can go into each individual tool and download it, and it has an overview for you of the tool. You can also download all programs or all tools from a specific work stream. So it works both ways. It allows you to look at very individual tools or look at a broader area all at once. So before we give you those examples of some of the highlighted tools that we have for you today, I'd like to let our presenters give you a little overview of their individual programs and how they've used the tools. So our first colleague to present is Jason Broad, who is the Director of Lean Six Sigma for Sharp Healthcare, and he's responsible for implementing Six Sigma, Lean, Workout, and Change Acceleration process at Sharp, and he's been central to their ability to improve operational, financial, and clinical performance in their system. I'll turn the program over to Jason to describe his intervention, and we'll then speak to our colleague Korey Capozza before we get into the individual tools. Jason.
Thanks, David. So as an extension of the organization's performance improvement strategy around readmissions, my group was asked to lead a number of initiatives around reducing 30-day readmissions for our Medicare populations. We were fortunate enough to work with CTA on a grant testing mobile health technologies, and we specifically focused on the underserved population and Medicare fee-for-service patients at one of our 4 hospital campuses. And in this particular program, we also focused specifically on patients with a primary or secondary diagnosis of COPD. Our focus was identified by looking at data and also looking at the programs or the gap in programs for certain populations. And with a high readmission rate in the COPD population, and recognizing that we didn't have as well outlined programs for this particular population, this opportunity seemed great in terms of being able to affect that metric for these particular patients. What we did in terms of the intervention is use mobile health technology to manage these patients from their home with a cellular-enabled pulse oximetry device, and as well a command box, which you see on the screen with the yes/no buttons. So the patients will log in every day, they would answer a series of yes/no questions about their health, and they would also get a pulse ox reading, which would transmit to the monitoring nurses in Minneapolis, and those nurses would respond to the patient on exception based on their daily reads. We also had a nurse who was central to the program. We call her the nurse coach, and she would do at least 2 home visits to the patients, unlimited telephonic support, and she would also work in concert with the monitoring nurses when the patients had needs that needed to be addressed by someone that had developed a relationship with the patient, and in some cases somebody that could actually go to the home and work with the patients and their families. On the next slide, you can see the results of our program, and we started with a baseline at 22% for this particular population. We looked at national average for all patients, primarily because it's difficult to get any benchmark data for a very specific payer-based population. But our goal was to reduce by 30%, which a lot of the literature in the readmissions arena starts out with a baseline of 30% as an accessible reduction for most programs, meaning that in this particular population, at least 30% of the readmissions are preventable. And you can see when we look at our patients who completed at least 30 days of our program, we dropped the readmission rate from 22 to 15%. So on the next slide, you can see some of the lessons that we learned in this program, and I'll go through those. The first one is that the recruitment of staff in a particular program like this is critical. This is the type of job for someone who wants to do more, not necessarily do less. And I say that because we heard from a number of applicants to our positions that folks were looking to get away from the bedside, or they wanted something less hectic than some of the hospital-based work that they were doing. And we knew intuitively that this was the kind of program and model that would require a nurse who was passionate about their patients and would do everything it took to help these patients who are struggling with chronic condition to be successful. And so we really needed to find the right person who would make this program and our patients successful. And so we were delayed a little bit getting started, but ultimately we found the right staff, and the time spent paid off in the end. The second is that the program can't help every patient, and we had to be very aware of who would benefit from this type of program and what those specific inclusion and exclusion criteria were, and then make sure that we stick to it exclusively. Now, I will be honest, in the beginning we did have some learning with this in terms of we set up our program selection criteria and realized after moving away from it a few times that we really had to be strict in terms of allowing patients into the program that could be successful. So patients that are too early in their diagnosis, this won't be as effective for, because maybe it's a little too intense, and they can be successful with something that's less intense or less costly. And just the same patients that are much further along in their disease state, maybe they need a palliative or pre-hospice kind of program, and that this program wouldn't help them either. And then last, understanding that technology in of itself is not the solution, but that it's part of a program that we put together with a nurse coach that uses technology as a way to help patients become better educated about their disease and what it takes to be well managed at home and in the community. That the technology, along with the nurse coach, helps the patient develop confidence in that they understand how to take care of themselves and what it means when their symptoms are getting worse and what they need to do. So we're helping them understand what to do and have confidence in their decision making, and all of that ultimately improves their activation. That if we give them a tool to help them develop a routine and a ritual, if they become educated and they're confident about their care, then they'll become more engaged at driving their care and more accountable for their outcomes and ultimately have better outcomes. In terms of using the toolkit, on the next slide, we were successful, I think, for a number of reasons. We actually didn't have the CTA toolkit when we started. We helped them put it together, but we were anxious in terms of participating because in getting this program off the ground, had the benefit of a number of resources that ultimately became my toolkit. I worked with another part of our organization that was using remote monitoring. I worked with some of the drug companies that had fantastic education materials that we could use. And we also relied on some of the documentation from the remote technology vendor, and we used their documentation to help us go from idea to enrolling first patient as quickly as possible. And what we found is that when we use the documentation, not only do we get started faster, but we start to see that impacting our ability to be successful with the program because we're using that which comes from reliable organizations that have been successful with the same kinds of programs. And the third point, that this becomes our change management strategy, refers to when we're talking to patients and other key stakeholders, particularly physicians and nurse specialists, and we tell them how we put our program together and the other organizations that helped us put the program together and how successful they've been with their programs, we noticed that we got buy-in a lot faster because we weren't trying something that was brand new and starting from scratch, but we were borrowing from the best of what others had used and been successful with. And that helped us tremendously, particularly on the physician side. So as a change management strategy, using toolkit from organizations that have been successful will get people to buy in and accept the program. And that's what we noticed in our particular, our two programs with remote monitoring, that we had buy-in because we shared our program, developed it from others who had been successful. Thank you.
Thanks, Jason. Now I'd like to also let Korey Capozza give us an overview of her program at HealthInsight. Korey's the Consumer Engagement Director at the Utah Beacon Community Project, which is coordinated by HealthInsight. And she leads the mobile health pilot that was funded by both CTA and Beacon. But she also is responsible for HealthInsight's public reporting website, their online patient tools, and social media initiatives. So Korey will take us through the specifics of their mHealth initiative before we then look at some specific examples of the tools. Thank you, Korey.
Thanks, David. And it's a pleasure to be here to share our experience with everybody today and also to highlight some of the offerings of the toolkit, which I think is just a tremendous resource for the community. As Alex mentioned, each Beacon community has a particular clinical focus, and ours was on type 2 diabetes, looking specifically at the adult population. We recognized early on that type 2 diabetes is a largely self-managed disease, and so we implemented a number of programs aimed at really supporting patients with self-management tasks. And one of those programs was Care4Life, which is a mobile phone-based program that had a number of characteristics which were particularly attractive to us. One is that it uses simple SMS short code, so it didn't require a patient to have a smartphone or an app or something more sophisticated, and it was accessible to anyone that had a basic cell phone. And as it turned out, we found that many patients in our population had very old or fairly primitive cell phones. Second, the messages were very well vetted. They were based in science and followed national standards, and that was important for us, but especially important for our physician and provider partners. Third, it was available in both English and Spanish, and we had 3 clinics participating in our program that served primarily Spanish-speaking patients, so that was a nice feature. The messages could be customized and personalized, so rather than appearing as though they were coming from a computer, it gave the impression of coming from a person. And in fact, the program was set up so that the messages came from an avatar named Paula, so there was a particularly personalized and human component to the program. Messages themselves were related to diabetes education and tips, reminders around glucose testing and taking meds, and then health behavior coaching. It was a 2-way interactive system, so patients received reminders, for example, to check their blood sugar, and then they texted in their most recent blood sugar reading. After that, the program would respond with some coaching and tips on how to improve or some congratulations if they were doing really well. Next slide, please. So we deployed this program in 19 primary care clinics that were part of the Beacon Community Program in Utah. All of these were small, independent, unaffiliated practices, so they weren't part of a larger health system. And they had fairly limited resources as far as care management and care coordination. We identified patients through the medical record, and we actually enrolled patients in 2 separate groups. One was a study group that was under the framework of an IRB-approved research study, and the second group was part of the larger Beacon quality improvement effort. So in total, we had about 450 patients enrolled in the program, and we had a lot more data on the first group, the study group, as we had access to their medical record and so on. The invitation to join the program came from the patient's physician or the clinic, and we felt this was important to maintain the connection to the care setting and the care team, even though the program was fairly standalone. Enrollees, as it turned out, were older. They were 53 years old on average, and they were fairly tech unsavvy. We discovered in a survey during the recruitment stage that their familiarity with the web and text messaging was below the national average in every case. We had data for the study group on a number of aspects. First of all, their usage patterns, so looking at their engagement with the tool. We had patient satisfaction survey data, as well as clinical outcome measures, which we collected at baseline, the midpoint, and at the end of the study, which was at 6 months. Next slide, please. So lessons learned. We really, in retrospect, did not invest enough time on the front end, helping patients with enrollment, training them in the program, teaching them in some cases how to text message. Our patients needed a fair amount of help with just navigating the web and understanding the text message features of their phone. But once enrolled and once they were trained and they got over that hump, they really seemed to do well with the program and to use it fairly easily. We found that the part that seemed to resonate with patients, and this is somewhat anecdotal, is the coaching and the feedback aspect of the tool. Self-tracking alone didn't seem to be the part that attracted patients, but the encouragement and the coaching and the feedback to the tracking was key. Similar to what Jason said, I think we really need to start developing a more targeted approach with these tools. Clearly, they're not for everybody, and so to start to look at the data and to understand what characteristics are likely to predict success, I think is going to be really important. And we did start to do that with our data and have some ideas about, where best to really push these programs in the future. And then finally, in terms of scaling and catalyzing future adoption, one big barrier that we encountered was the fact that our primary care clinics are so busy. There's really no give in anyone's schedule, and they're operating on pretty slim margins. So under current payment models, it's difficult to ask folks to do more, such as recruit and enroll patients in these types of programs. But I think as we start to look at different reimbursement models, such as accountable care and so on, there'll be a more logical place for these kind of programs in new payment environments. Next slide, please. So similar to Jason, we did not have the benefit of the toolkit before starting, and I can say we sure wish we did. This is a fabulous resource, and I think a huge benefit is that it lets other communities learn the easy way. So you can forego the sort of trial and error process that we went through and really just jump to implementation with strategies that are proven and that have already worked. Second, as I look at the resources that are there, the focus on the nitty-gritty and the specifics and the details and the instructions is so important. And it really helps people take action rather than just speak generally about the need for patient or provider engagement, which is perhaps more obvious but harder to actually implement in practice. And then finally, similar to the Beacon Nation project, I think this toolkit, as well as the Beacon Nation resource, really saves resources because it helps us spread knowledge from our isolated pilots to the broader community and prevents the sort of reinventing of the wheel that seems to happen, in part because results from pilots and studies and community-based efforts are reported in terms of results rather than how-to. And the how-to is just as important and so beneficial, I think, in the broader context to the broader community. So with that, I'll pass the baton back to David. Thank you.
And thank you, Korey. So at this point, we'd like to quickly help you see some of those tools that have been assembled that do address some of the issues that Korey, Jason, and our other colleagues have faced in implementing programs. So while there are a host of different approaches, we've just decided to show you some that cover some of the points relevant to the programs that they described today. So we'll move through these relatively quickly because they are obviously accessible on the website, but want to give you a flavor for what is there. So first, one of the key issues that both Korey, Jason identified is the challenge of how to enroll individuals, how to identify them and make sure that they are the right fit. And in this case, we have a number of different tools that have been assembled under the patient management and program planning components of the toolkit to help you look at those key issues. Korey is going to speak very briefly to some of the patient recruitment strategies that they used at HealthInsight.
Yes, and as I recall, templates for these different approaches are available in the toolkit to help others get started. But we did try a number of approaches, mailed letters, phone calls. We even did health fairs in the waiting room of the clinics where we signed up patients on the spot. We had an online enrollment option, and then one of our clinics actually took on the job of recruiting and enrolling patients on their own and really worked it into the patient visit and the workflow. And as it turns out, that last approach was really far and away the most effective approach. But I think we tried a number of approaches at different times, and they all helped us to enroll patients through different avenues. Next slide.
And once you are able to get individuals into a program, identify those that are appropriate, a key issue that all of the programs have identified is getting the patients engaged in using not only the technology, but in really focusing on their own health care and addressing the chronic care issues that they've been looking at. And we were able to assemble a very nice series of educational materials, action plans, and specific vignettes that people can use in this regard. Jason will mention a few of those that they used at Sharp Healthcare.
So this diagram that you see kind of shows you how we introduced the patient to, or at least explained to the patient, how the mobile health technology was going to work. And I think the key here for engaging the patient, at least at the onset, is, and it almost gets to the patient recruitment piece as well, is that we invited the patients to participate in this program as an extension of the great care that they were receiving in our facility. So we really tried to make it seem as seamless as possible, and they were being part of a program that had a specific pathway and worked in a specific way, but we were really trying to show them that this was part of the continuum of care that we were providing for them, and explain to them how it was going to work, particularly with the health coaching as one of the strongest patient engagement strategies, where we coached the patient. We didn't do things for them, but we helped them understand what was happening and how to manage their disease with very specific coaching techniques, some of which we borrowed from some of the work that's out in the public domain with the care transitions intervention, and really help the patients understand what to do when things happen. And an example of another tool that we used is the action plan that is kind of a green, yellow, red format, where we educated them on their disease, helped them understand what's happening, and then we helped them put together an action plan so they know what's happening when they're doing well, they know what's happening when they need to intervene, and they know if they're in danger and what they need to do in those instances. And our goal was really helping them stay in the green or navigate from yellow to green. And we used this particular document from Boehringer Ingelheim, one of our partners. And the third important thing about this is kind of an extension of what they were receiving in the hospital. And so to make this seamless, we had to make sure that we weren't bombarding them with different education materials at every touch point. And once they got the idea that this was part of the continuum of care and it was an extension of the great care they were receiving in the hospital, they started to sort of engage a little bit more.
Since we've talked about patients, we wanted to also mention some examples around provider engagement and how one can really get providers excited about using an mHealth solution. And we have 3 different examples. We'll turn this over to first Jason in terms of just some of the, well, Jason and Korey, some of the clinical vignettes that we've seen used very effectively to reach providers.
So one of the foundations of our culture at Sharp Healthcare is the idea of storytelling, and we used this concept as a way to get providers, both physicians as well as nurses in the facility, on board with what we were doing. And you can see one of the examples here. We have one of our health coaches in her interaction with these care providers explained to them what was happening as a result of using the technology. There's a number of stories, and this one, for example, that you see on the page kind of refers to a patient who couldn't get her pulse ox above 80, and we, using the mobile health device, worked with her in the home to understand what it meant to be at 80 and what she needed to do to get it to 90 and above. And we kind of walked through with her taking a pulse ox at multiple times in this interaction so she could see how what she was doing affected her ability to breathe and thrive at home. And the story, in of course much more detail when given the luxury of time, really kind of is a testament to how well the technology facilitates the patient understanding their condition and taking care of themselves.
Yeah, and I think just quickly, even people who are primarily motivated by data, the personal stories are extremely powerful to show the human impact and the human side of these programs. So in terms of recruiting both folks in the provider community as well as patients, these vignettes, I think, are really impactful. Okay, so this one is me, I think. In terms of provider recruitment, we had about 75% of the providers that we approached agree to participate in our program. And I think all of these selling points resonated, but the one that probably resonated the most was really the recognition that we need new resources to help patients with self-management, and providers get that. They know that they see their patients for 15 minutes on a quarterly basis, and what the patients need to do the rest of that time is really hard, and they have to achieve it without a lot of support. So I think making the case for these tools as adjuncts to care and as resources for patients to succeed when they leave the physician's office is a very powerful argument. I think there's a certain sexiness to new technology that also appealed to people, attention to patient privacy, and really looking at that issue of minimizing new work, of course, is going to be important as well.
So one of the things that we found helpful, and for those of you that know a little bit about Lean Six Sigma, it's no surprise to see some sort of workflow document used in our program. But this was a way for us to really get a sense of the pathway for our patients, and then it became a significant piece of collateral in talking to the physicians and nurses who were part of our referral stream so that they could understand what was happening to the patient while they were enrolled in this program. And they could also understand the different pathways if the patient was succeeding or if they weren't succeeding, making sure that we were closing the loop to transition the patient, for example, to hospice if that was where they needed to go, or to continue them on remote monitoring after the duration of our program. So they had a sense of confidence that we had thought through how the patient would work within the program and then what happens when they're finished with our short intervention. And I think that sense of having a full sense of the pathway helped people understand that it was a good referral source, and that's what generated for us more referrals from the physicians and the nurses.
So we have two more examples for you. One, very briefly, I'll just mention in terms of the challenge of trying to scale a program, really take what's been a pilot in most organizations and then start growing it. And we have a few examples here that you can turn to. We won't go into any detail right now about everything from focus groups for how to work with providers to learn what works and needs to be done within an organization to actually providing several different tools and forms and presentations that can be used with senior management in terms of how to carry back information in terms of how they can best be used for moving a program forward. But the last one we'd like to speak to is sustainability, which is the ultimate goal for all programs who have looked at this. And one of the key issues that came forward from all the grantees was the need to actually understand what the potential return on investment would be and what it was actually. And to do that, we collaborated with our colleagues at the Center for Connected Health in Boston, who helped develop an ROI calculator for people who are looking at this, either trying to decide to move into this area or once they've implemented an mHealth or telehealth solution, look at the results that they've had in order to make decisions as to how to improve that program and how to best move forward. Jason participated in this process. I'll turn it over to him to give you an example of the ROI calculator. But please note before he does that, on the previous slide, and at the end, we have the new link as to where the ROI calculator can be found. We will have all those resources listed at the very end, but it's at www.telemedroi.com. Jason.
So we were fortunate enough to work with CTA on using and developing their ROI calculator, and it's turned out to be quite a helpful tool in two of our remote monitoring programs. But we also look forward to using this model for a couple of other programs that we're testing out. What's been put together and what we used is a very simple tool for entering in data about our program to understand the financial benefit of the program. I found it to be particularly easy to use in that I think the idea of doing an ROI analysis to most folks that are focused on taking care of patients and improving chronic condition can be a bit overwhelming, and this thing, in the way it's put together, spells out very easily the elements that one would need to look at to understand if the program was producing a positive ROI. And the benefit of this tool is that it projects out based on the estimates of an organization's enrollment, what the ROI could be year over year leading up to 5 years. The other thing that's particularly helpful about this ROI tool is that there's a sensitivity analysis option at the end that allows a user to play what-if scenarios. So what if I enrolled 20 more patients, or what if the cost of salary was a lot less? And so it could really help look ahead to see what does someone need to do to ensure their program is successful in whatever terms that is for your organization. I think we want to make sure that we're providing good service to the patients, but we also want to make sure that it's cost effective, and that's what I found this tool particularly helpful for. And it also helped us kind of test out a couple of other models. Well, could we do this program with a different type of staffing, or could we do it with different levels of nurses involved, maybe RNs versus LVNs and that sort of thing. And so we were able to not only assess the ROI in our pilot of our program, but what it would look like many years out. The one thing I will note is, for us at least, we struggled with the ROI in the first year because we put so much time and effort into getting the program off the ground that we were optimistic with this tool, and that we could look at what the ROI would be with the lessons learned, and what the program would look like after we paid for our own learning. And initially we weren't as we were encouraged with the results that there was a lot of learning in the first year, and maybe we got to about a break-even point, but applying that knowledge and expanding our program with more patients and a higher caseload, we were pleasantly surprised at the positive financial outcome. And you can look at the next slide, which also shows you kind of a forecast of what the programs look like in a long-term period in terms of what's the ROI and what does it look like year over year based on the different cost categories for the program. And this kind of gets back to what I said earlier, that the program really is thoughtful about looking at all the costs that would go into a remote monitoring or an mHealth kind of program, and prompts the user for all of those particular elements so that you're sure that the ROI reflects what your program is doing and the cost that you incurred. And the sensitivity analysis is the last element you see there. That's what I mentioned earlier. That allows you to play the what-if scenarios as well. So very beneficial, and also very thorough in terms of being mindful of all the costs.
Thank you, Jason. As we wrap up, I would like to share with you that we have received a number of questions. We'll be happy to respond to those offline, but just very quickly, in terms of whether you can submit tools to this website, we absolutely would encourage that, and we would look forward to receiving those, and we will be adding additional tools as they come online. In terms of moving to the next area in terms of resources, please do not hesitate to contact the center in terms of any assistance that we can provide with using the toolkit, but also in terms of looking at other aspects of moving into mobile health and telehealth issues. We are available, and that is the focus of our organization. In terms of today's material, we have a list of the additional resources on the next slide, which will show you the different websites from which you can get those. The entire webinar will be posted shortly on the CTA website so that these will be accessible to you. And finally, would like to not only thank all of our presenters, Alex, Korey, and Jason, but share with you that we will post on the next slide their specific contact information. So with that, we want to thank you all for joining us today. We look forward to your successful efforts in this area, and please do not hesitate to contact any of us regarding specific initiatives, and particularly the ADOPT Toolkit. Thank you again for joining us today.